switch to the other one too if you'd like to do that one first.
Okay. Nope. This one, the first one, the 69-year-old male is perfect. So this is a 69-year-old male who recently started seeing me for his hepatitis C. He does have Medicare, and is he on Medicaid as well, or was he straight Medicare? With Medicare with a Part D plan. Okay, good. Medicare with a Part D plan. He has a history of intravenous drug use, mostly back in the 70s. And he also had some workplace exposure to blood got in his eyes. He was treated for hepatitis C in the past, and he was told that it was cured, and that was for over a year. And he did complete the treatment, and he says that it was all done correctly. And so it does seem like he was a treatment failure. He states that he did not have any risk factors after the treatment, and then about a year afterwards, they did a viral load again and found that that he did have the virus again. So I'm not totally sure. Hopefully, you guys can shed some light on that. To me, but it does seem like a treatment failure or a reinfection, but he didn't seem to have risk factors for reinfection after the fact. He does have cirrhosis of the liver. He's got type 2 diabetes, hypertension and edema. He was not immune to hepatitis A, but he was reactive to hepatitis B. And so we are giving him hepatitis A vaccines. And so if we start looking at his numbers, he does have obesity with a BMI of 49.8. Otherwise, his blood count looks pretty good. His platelets are normal at 249. His creatinine slightly elevated at 1.3. Sugar's a little bit high, but does have a history of diabetes. His INR was slightly elevated at 1.2. His AST, LAT, both mildly elevated. Bilirubin, pretty much fine. Direct bili, pretty much okay. He is Child-Pugh class A with a MELD score of 11. The rest of his labs, pretty much looked okay. He was vitamin D deficient, as all of our patients are. So we got him started on some vitamin D, and he's genotype 1A with a viral count of about 3 million. And then his fibrosis score was, I believe, an F4, because he does have cirrhosis. But let me just pull that up here since we recorded that differently here. Let me make sure that he did have an F4 on that. Yes, F4 cirrhosis. And his necroinflammatory activity score was an A2, so quite a bit of inflammation. So that's him. So our questions are, he's type 1A, but he does have that history of treatment in the past, and then reinfection or more likely treatment failure. And so we would just be looking for suggestions on treatment regimen because of that. And then, of course, with his history of cirrhosis, we do have to be pretty careful, but he seems to be a compensated cirrhotic. He does not have a history of a TIPS procedure, which is good.
Awesome. Thank you so much, Dr. Bailey. Was there any recommendations and feedback for Dr. Bailey in the case, from the hub or the group?
I can start if no one from the spoke wants to speak. If you guys have any questions, I'll let you guys go first.
No, Kaylee, it's John. We're not going to steal your thunder at all. I appreciate you talking on this one.
Well, I was hoping Dr. Bailey would stay for the didactic because, girl, this was aimed at you.
Oh, no, I'm so sorry.
It's okay. I want you to, I want to make sure, though, that you get the opportunity to try to listen to it later, though, because I actually made the didactic for a case you presented a few weeks ago on a treatment experienced patient, and now this gentleman. So I think my first questions for you, other than thanking you for presenting two complicated cases lately, is that, your questions about his prior treatment, it's a little bit confusing if he said he took a shot and it was for a few months. I would try to sift into kind of further details as far as, you know, how long ago that was. And then, you know, if or if it was for 6 months or 12 months or 3 months. I'll tell you something that's super basic, but I've had, and it sounds like this gentleman doesn't fall in that category, but I've had patients that were under the impression that they got treated for hepatitis C, and it turned out that they actually just got Hep A and B vaccines.
Gotcha.
So they thought they had treatment because they went through a series of shots, but in reality, it wasn't really Hep C treatment. They just didn't understand the difference with viral hepatitis. So, I mean, it's interesting, and I honestly would not have thought about that until I had somebody that I messed up with because of that, because I totally thought they were treatment experienced until I found that out. So, learn from my mistakes, but that's one thing I would point out. And then you know, generally speaking, you know, if he did, it sounds like just if he took shots, you know, he was treated with in the interferon era. And so as far as retreatment, for the most part, it's very similar to treatment naive, with the exception of cirrhotics who have genotype 1A, which is this gentleman. So
right.
I think kind of first things first, before we talk about your treatment options, you know, we know this guy's cirrhotic. He's probably been for probably 30 plus 40 years, if his risk factors were that remote. I noticed that his AFP was a little bit elevated. It was 12.8, and then you know, that the upper limit of normal would be 9. And so my first question is about imaging modality, if you've had any imaging on him. And I know you knew I was going to ask that.
I did. We have an ultrasound scheduled, and he's also scheduled for an EGD to screen for.
Okay, beautiful, good girl. And I mean, overall, you know, even with his classification of cirrhosis, we can say he's well compensated. He's not, his platelets aren't low. You know, his child's Turcotte is still class A. So I wouldn't, you know, necessarily worry about him being decompensated, but I would still make sure you're getting that good assessment of HCC. Now, sometimes even the AFP can be elevated even just with hepatitis C that's cirrhosis. I would just kind of, if your imaging doesn't suggest any abnormal lesions, you may not necessarily feel the need to go ahead and proceed with an MRI to look for further liver mass. But if you note that his AFP continues to increase, so a 12.8, and the next time when it's checked in 6 months, it's up to 300, then I would probably order an MRCP on him.
Okay, gotcha.
But that was kind of my first question, was just to see if you had an imaging modality set up for him. The other thing, you know, SVR rates historically with prior treatment, particularly in the interferon era, were much lower in patients that have cirrhosis. So if he's had established cirrhosis for some time, plus with his genotype and the older agents, you know, he probably, even if he did get full treatment, had a kind of a lower likelihood of response. In his instance, you know, your treatment options are going to be our normal go-tos, Epclusa and Maverick. Those are kind of the two I would tend to prefer, both for 12 weeks. Zepatier is another one that we don't really talk about that much, but it would still be that NS5A polymorphism baseline testing that you'd have to get. So that's probably not your go-to.
Right.
Harvoni, another one, but interestingly enough, in this instance, since he's cirrhotic and we'll assume he's had prior treatment with interferon that was failed, you know, you'd actually have to add ribavirin to it. So that is another reason, and also do resistance testing. So that's really another reason I probably wouldn't go with that one initially. I saw his med list, and I don't really see anything that's going to interact with either Epclusa or Maverick. I generally kind of tend to go with, you know, if you're able to try to avoid protease inhibitors in our cirrhotics. Usually we worry about the risk of liver decompensation or liver failure with those that are kind of borderline decompensated. But if you have more than one treatment option available, I kind of try to tend to choose the lesser of two evils. And so we don't tend to see that progression as, or liver failure with our compensated cirrhotics as often with sofosbuvir containing regimen like Epclusa. So I would probably go with Epclusa if you're able to get that covered, and then if not, Maverick.
Okay. Yeah, I think Epclusa is a great option for him. Yep. Awesome. We will do it, and that'll be 12 weeks.
Yep.
Okay, cool. Sounds good. We'll do it.
Thank you, Kaylee. Did anyone else in the group, the participants, have any questions for Dr. Bailey or anything?
No, I'm good. Yeah.
You have one question. With the Medicare Part D, they sometimes have a lot of a big copay on their medicine. Would it just be, are these usually like brand preferred? And so they have like a $45 copay, or it's gonna like flip him straight past, you know, donut hole into catastrophic. So does that make it a zero copay? How does that work?
It's really going to depend on what his, and I wish Rachel were on, because she's so much better versed than I am in this, but it really will depend on, you know, kind of where he's at as far as meeting his limit at this point in time, and then also his particular Part D plan. So
Okay.
It really depends on what the what his particular plan, like what partnerships they have, if they have a better contract with a generic versus the brand. But you should be able to get, hopefully, patient assistance with either one. There's
Okay.
If he has secondary Medicaid,
He does not have secondary
okay,
Medicaid.
I thought you had said that in the beginning. Okay.
No, he doesn't.
I'll have to pull it up because I don't have them off the top of my head, but there are
It's okay.
there are several Medicare patient assistance programs specifically for Medicare patients. I'm blanking right now. Not GoodRx. There's another one that tends to be used a lot, but I cannot think of the name right now. But tend to help reduce that cost, particularly with Part D. So
Okay.
I can send out, really or if Rachel has a spreadsheet already on offhand, I'll have her send it out. But we'll get something to you for help with that.
That sounds good. Thank you.
Sure.
Dr. Bailey, were there any other questions before we go to your other case?
Nope. I'm ready to do the other one whenever you guys are.
All right, awesome. Let me pull it up here. All right, I'll turn things to you.
Okay. So this next patient is a 46-year-old male who also relatively recently started seeing me for his hepatitis C. He smokes, he does not drink, he has Medicaid unit care. He has some depression and anxieties, hypertension, some peripheral neuropathy. Who knows what that's from? Maybe it's hepatitis C. He has a seizure disorder that was secondary to an old head injury, and there's more there about that if you can look at it. He also has some chronic pain issues. Let's see, medication-wise, that Aristata, I honestly don't know what that is. I meant to look it up before we started, but there it is. Aspirin 81, vitamin D, glycopyrrolate, hydroxyzine, Keppra, naproxen, and pyridoxine. He is a former injection drug user. He has unprofessional tattoos. And he was first diagnosed with hepatitis C in 2020. He has received both his hepatitis A and hepatitis B vaccines. He is not over, or he's barely overweight, not obese. Lab-wise, labs don't look too bad. Hemoglobin's okay, platelets are okay, creatinine's fine, sugar's low, his INR is normal, his AST and ALT are close to the normal range there, his bilirubin looks okay, protein's okay. His Child-Pugh, he's class A, and his MELD score is 6. Iron studies look pretty much okay. Vitamin D was a little low. We started him on some vitamin D. AFP is normal. Does not have HIV. He's genotype 1A with a low viral load at just 11,000. And then again, let me look at that fibrosis score in this chart here. I can tell you what that is. There it is. fibrosis score was F0. So, and his necroinflammatory score was A0 to A1, so not too bad at all. So this is a guy that is pretty darn straightforward. I think Medicaid will probably cover his treatment since they got rid of the cirrhosis requirements. He's one that we've had a little bit of trouble with compliance as far as keeping up with his appointments and things like that. And so right now we're kind of, I figured I would go ahead and present him just so he would be ready for treatment whenever he's ready for treatment. But I don't necessarily think that he's 100% ready for treatment yet. When he is, though, my thought was maybe Maverick for him. We just need to double check those the drug interactions and make sure that there's nothing there. He, I think, would do fine with 8 weeks because of that really low viral load. And of course, Medicaid will make us have 6 months on that viral load. And I guess it is possible that he may clear. This could be an acute infection, but I kind of doubt it.
Thank you, Dr. Bailey. Before we jump into any of the recommendations and feedback, are there any clarifying comments or questions for Dr. Bailey? And thank you, Dr. Rexford, for chatting in the name of the injection.
Thank you.
No questions. All right, any recommendations from the hub members?
Dr. Bailey, hey, it's John here in Wheeling area. Just a couple comments. I guess first and foremost, a very advanced thought process as always. And I agree with you about your conclusion. I would choose some short treatment course, whether it be Maverick. His viral load is very low. He could be a Harvoni 8-week guy. He's non-cirrhotic, or Nepclusa 12-week guy. So any of the treatment options seem valid. In terms of drug interactions, I'm not near a computer that can do it, but you know, if you ever see someone who has anti-epileptics, they're one of the categories of drugs to be cautious with, but I believe Keppra okay. And that's going on memory, which is always faulty, and potential to be faulty. Hopefully not always faulty, but potential for it. And so anyway, I think just making sure that you double check that one in particular. The only other cool part about his case that I liked was, you know, this peripheral neuropathy in his history. So if we're trying to think of a reason to sort of advocate for treating this guy, because we don't really find anything with regard to hepatic manifestations of concern, but peripheral neuropathy is one of the relatively common extrahepatic manifestations of hep C potentially. Mechanistically, it tends to be related to occult cryoglobulinemia. So it's actually vasculitis of the vasa vasorum, and you get neuropathy from that perspective. So it would just say, hey, maybe this, by the way, you can't prove that. If you did cryoglobulins, it might be positive, but whatever, you know, you're going to try to advocate treatment for him, and just extra motivation to get him to go that direction. And so maybe it's not his liver that would make us want to advocate for more rapid treatment. Maybe it'll be his potential for extrahepatic manifestation. And I realize from his history, probably has other reasons for neuropathy with a brain injury or something. I can't remember what else is in there, but anyway, I can't come up with anything to make his case more complicated either. So any of those 3 drugs seem perfectly fine, and nothing from my eyeball test said interactions are a concern.
Gotcha. Do you know if there's outcomes data for the neuropathy, if those folks get better after they're treated?
I don't, but I'd imagine that those ones would be a tad of a challenge. It is a peripheral neuropathy, so they could improve with time, but it would not be rapid. Yeah, so anything that's a peripheral neuropathy, it's a relatively slow improvement. So, but you could probably hold that carrot out as something that potentially could be improved if you treated them. You know, if I'm thinking about the mechanism, cryoglobulinemia normally does improve with treatment, and the cryoglobulinemia is assumed to be the pathophysiology of peripheral neuropathy. So, and peripheral nerves grow back. So, if A plus B equals C, then I'm not just BSing you, but okay.
Word of the day right there. All right, cool.
Awesome. Thank you so much, Dr. Gilfus. Were there any other comments, questions, thoughts that you wanted to share with the group before we move to the didactic portion? Dr. Bailey, anything else you wanted to ask?
No, I don't think so. I don't think so. I appreciate you guys. I'm sorry I have to run in. I promise that I will watch the didactic. You'll get it up on YouTube, right?
Yes, we sure will. I'll send you the link.
Thank you. Thank you.
All right. Well, thank you so much, Dr. Bailey. We really appreciate it. And
Thank you,
we're
guys.
glad you could join.
Yeah, me
Thank
too.
you.
Bye-bye.
Take care. All righty. Well, Kaylee, I can pull up your didactic for you, and I'll just turn things over to you then. Just let me know when you want me to advance your slides, and I'll make sure to do that.
All right, so I'm going to talk about HCV treatment experienced patients, and this is specifically aimed at genotype 1. The guidance has multiple tables in regards to treatment experience, and it's all categorized by genotype and cirrhosis status and whatnot. So today we're just going to focus on genotype 1 because this is what we most commonly see with our retreatments. Go ahead and advance the next slide. So I think it's first important to just kind of revisit the evolution of hepatitis C treatment. This timeline spans over, 30 plus years, really, with the introduction of interferon in the early 1990s, and then our first pan-genotypic agent, which is a brand name Eclusa, was introduced in June of 2016. And so you can see over the last 30 years, SVR rates have drastically improved. So if you look at the little numbers above the bars, back in interferon with the additional or in introduction of interferon, it was less than 10% SVR until, in current landscape, it tends to be near 100%. And so a couple things that I really wanted to with this is that not only have SVR rates drastically improved, but our treatment duration has significantly lessened, whereas it used to be 6 months, 12 months. Now we're seeing treatment narrowed down to as little as typically 8 to 12 weeks. Some studies are even being shown with 6 weeks of treatment. I'm showing some success. And so, oops, I lost my slide real quick. Hold on just a second. Sorry about that. I lost my slide.
Kaylee, do you want me to try to
Yeah,
stop
maybe.
sharing?
I don't know what happened to it. It's
Yeah,
like,
no worries.
it's like, okay, there I see. I see me.
Let's see.
It's you. Sorry about that.
No, you're totally fine. Is that better?
Okay, now I can see it. Sorry, I
Okay.
think I clicked something.
You're perfectly fine.
So really, I mean, just like the point that SVR rates have improved dramatically, treatment duration has lessened dramatically, efficacy, tolerability of these agents has improved as well. So just kind of understand the landscape of things. Treatment history should be assessed in all of your patients at initial HCV treatment evaluation, not only because it can help guide, as we'll talk today about hepatitis C retreatment if that's indicated. But another thing to think about is if you have a patient that was treated in the interferon era, or their only frame of reference is knowing someone that was treated in the interferon era, there's a lot of negative bias towards hepatitis C treatment. So interferon treatment, there was a lot of adverse effects, low SVR rates, and so patients may actually be fearful of hep C, might not verbalize that that's their fear, is that they have this idea that they're going to have to be going through injections for months and months. They're going to develop cytopenias or suicidal ideations because of treatment. So a couple reasons why it's important to kind of clarify that treatment now is very, very much different than it was several years ago. Next slide. So understand, in the direct-acting antiviral era, we have multiple highly potent DAA combination regimens. We don't use any DAA monotherapy, and I'll kind of explain why in a little bit, but these are all available for retreatment. Some factors that you want to consider when selecting your retreatment option. So today we're only talking about genotype 1, but make sure you're genotyping and subtyping if understanding if there's any presence or absence of baseline NS5A resistance associated substitutions, or RAS, which we'll talk about that. The presence or absence of compensated cirrhosis, and then what types of prior failed regimens, and the circumstances surrounding treatment failure in the past. And so example was the patient a non-responder, as in they never had undetectable viremia on their prior treatment, or was early because of adverse effects, because that can matter. Next slide, please. So our NS5A resistance associated substitution. So what the heck is this? I know that we kind of refer to this, particularly been talking about either in our treatment naive patients, either Zepatir with genotype 1A or Epclusa with genotype 1-3 cirrhotic. So we've thrown, when do we need to do this polymorphism testing out there, but what is it actually? And so basically, hepatitis C virus, it's highly replicative. I mean, this is like billions of virus are replicated daily. And this virus is actually really error prone. So each replication cycle, there's 1 to 3 errors. And that typically doesn't matter. A lot of times those errors can actually render the virus inactive, or they react on treatment outcome. But if the errors kind of occur at, really specific replication changes, then you can develop these, decreased susceptibility to treatment. And so kind of the way I want you to think about it is it doesn't necessarily render treatment with our DAAs completely inactive. It just can reduce the SVR rates. And so understanding that, 10 to 15% of genotype 1 patients, even without having any exposure to a DAA agent, will already have detectable NS5A RASes prior to treatment. And the reason why we talk more about NS5A, so remember our 3 classes of direct-acting antivirals are NS5A inhibitors, our NS5B inhibitors, and then our protease inhibitors. NS5B inhibitors, there's really a high resistance to, a high barrier to resistance. And so really NS5B, you only see about a 1% treatment failure rate. Our NS3 and NS4 polymorphisms, a lot of times we don't tend to see that as often. Also, if a patient has had prior treatment exposure to an older protease inhibitor, a lot of times within weeks to a month, to months of that virus no longer being challenged with that specific class of drugs, you see that resistance or those polymorphisms kind of disappear. They kind of get weeded out with wild type virus again, which is kind of the more fit virus. So NS5A resistance substitutions is what we tend to talk about more, because these are the ones that tend to decrease your SVR rates, and they also tend to last longer. So even if someone was treated with an NS5A inhibitor years and years ago, that resistance can still persist long after the drug is removed. Next slide. So a note about our patients with liver cirrhosis. Again, we go over this all the time. Fibrosis is typically defined as stage 3 or stage 4. And that lower SVR rates are typically observed among patients that have cirrhosis. And this is whether they're treatment naive or treatment experienced. The way that you kind of overcome either patients that have cirrhosis or patients that have baseline polymorphisms, you either don't use an agent that's more susceptible to a decreased, you add ribavirin, or you extend the treatment duration. So those are kind of the 3 mechanisms that we kind of try to overcome those lower rates of sustained virologic response. Again, we really don't talk about decompensated cirrhosis because we shouldn't be treating decompensated cirrhosis. That should really be managed by a hepatologist. And I think we can go to the next slide. So my subsequent slides really focus on the varying tables from our current IDSA and ASLD HCV treatment guidelines. if you go to the actual guidance, you'll see underneath the tables, there's all the studies, all the study data that kind of was comprised to make up those recommendations is listed below. I don't tend to go through all the data in detail. I really just want to compare and contrast what you need to know based on which prior treatment was used and whether the patient was cirrhotic or not, because it kind of gets muddled if I try to go into, you know, all of the really detailed data. So I'm going to go through the tables and then I can answer questions if you guys have about any specific data after the didactic. Next slide. So first we're going to talk about PEG interferon ribavirin experienced genotype 1A patients, and these are ones without cirrhosis. So if you look at this table, and then some of our learners today are a little bit newer, so I listed to the left of these tables kind of the brand names, since that's what we refer to these agents as. But this is for 1A patients without cirrhosis that have had experience to interferon in the past. So you still have Maverick. It's basically the same. You still have Maverick for 8 weeks, Harvoni for 12, and Epclusa for 12. You still have Azepatir as an option for 12 weeks as well, but you have to do that baseline NS5A testing. The only difference in those that have genotype 1B without cirrhosis in this group is that you don't have to check those baseline NS5A RASs for Elbasvir, so the agent within Azepatir, and this is essentially the exact same as a treatment naive patient. Next slide. So if you have a interferon experienced patient, genotype 1A with compensated cirrhosis, the biggest change that I want to point out, and this is what the case that Dr. Bailey presented today, is no longer a recommended. It's now changed to an alternative. It's 12 weeks duration, but you have to add that weight-based ribavirin. And so the reason being is that this one matters in the studies is that the fact that, you know, those that had Harvoni, either ledipasvir, sofosbuvir plus or minus ribavirin, the patients that had RASs had about an 80%, maybe a little bit over 80% SVR rate as compared to greater than 95% if they didn't have baseline RASs. And that was really comparable. The percentage was a couple higher percentage points. I think it was 96 to 100% if you use the weight-based ribavirin. But consider if you have to use Harvoni in this population, you might want to just consider checking RASs, because that did make a pretty significant difference in the SVR. And then the only difference with our genotype 1B patients with cirrhosis is that, again, you don't have to check those baseline RASs as you do with genotype 1A. Next slide. So this schematic is really focusing on our different classes of direct acting antivirals. We kind of tend to refer through ECHO the same 3 agents over and over again. But really it's important too, if you go back to that evolution timeline that I had presented with the first slide, you know, the older NS3 and 4A protease inhibitors, we don't tend to talk about that much. We don't tend to talk about decladisvir or bidisvir very often. So just kind of understand, you know, the first and second generations of these classes. You know, you may see, maybe not as commonly because SVR rates were still a lot higher than with interferon, but you may see patients that were exposed to these agents as well. And so the guidance with prior direct acting antiviral treatment is really categorized by, was it a prior NS3 4A protease inhibitor, or was it a prior NS5A inhibitor? And so you'll really need to kind of weed out what their exposure history was if they were certainly treated with another direct acting antiviral. Unfortunately, patients a lot of times don't know. They can't tell you, oh yeah, I was treated with boceprevir in 2011. They might be able to tell you around the time that they were treated. They might be able to tell you how many pills they took or for how long. And so that is a good reference, that timeline that I provide in the first slide, to kind of help sort out maybe what they were exposed to in the past if you're not able to get their old records. Next slide. So first we're talking about our NS3 protease inhibitors, and this is plus PEG genotype 1 patients that don't have cirrhosis. So this table actually tells you what those NS3 protease inhibitors are: telaprevir, boceprevir, simepravir. Glisapravir is the PI agent in Maverick, and grisaprevir is the PI agent in Zepotir. So those are kind of discussed later on, but it's generally the same 3 that we tend to use. Maverick is 12 weeks, and this is for patients without cirrhosis. So think you're going to be trying a newer generation PI agent in somebody that's already had a prior PI agent. So that's why it's a 2A rating. The only difference with, and then of course the Zepotir is listed as an alternate drug with weight-based ribavirin for both 1B and 1A after you've checked baseline RASs and the patient doesn't have those. And so it's a little bit more complicated to try to use that agent. Plus it's an alternative. I probably wouldn't go for that one. The only difference with a PI experience, so in the first or earlier generation PI with genotype 1 that has cirrhosis, and I didn't list this as a separate table because it's exactly the same, except that Harvoni is listed as an alternative option rather than a recommended, and then it's still 12 weeks, but you add ribavirin. So again, just kind of remember the aim is to optimize SVR, and the way we do that is by extending duration and adding additional agents. And so that's why Harvoni and Zepotir kind of drop to alternatives, because we have to do that in order to achieve similar SVRs with Epclusa or Maverick in these populations. Next slide. Okay, you can go to the next one. I think I just mentioned that. So in patients that have had NS5A direct acting antivirals, so this is not someone that's received Maverick. So the pibrentosphere is your NS5A agent in Maverick. So this is any NS5A inhibitor. So velpatasvir, ladiposphere, so Harvoni, Epclusa, even some of the older like declatasphere agents. These are patients that have failed that treatment, and this is with or without compensated cirrhosis. The recommended treatment, that's our salvage regimen. It's for 12 weeks. So this combination regimen is really all 3 classes. You've got your NS5B inhibitor with sofosbuvir, your NS5A inhibitor with velpatasvir, plus a new protease inhibitor that we don't talk about very often called voxilaprevir. And so by using this regimen, you're really trying to overcome those polymorphic and baseline resistance by the addition of 3 agents. And really SVR rates, whether they have cirrhosis, compensated cirrhosis or not, is over 96% with the salvage treatment. So really high SVR rates. Maverick, so you're using a newer generation PI. This one is alternative regimen, but you're extending the course to 16. That's why it's not kind of a preferred because it's a longer duration of this drug. Next slide. So for patients that have had Maverick treatment failure, glisapravir, pibrentosphere, and this is regardless of genotype. I know we're focusing on genotype 1, but this is regardless of genotype. You can do Vosevi for 12 weeks, or you can do Maverick plus sofosbuvir plus weight-based ribavirin, and that's for 16 weeks. If you're using Vosevi and the patient has compensated cirrhosis, then you would still have a 12-week duration, but you're adding ribavirin. So again, when we kind of think of the context, SVR rates with Maverick baseline are 97% and up, closer to 99%. So how often are you going to see this? Hopefully not often at all. But just kind of understand, you know, there are retreatment options even in this instance. Next slide. And I'm almost done. So just a point about treatment interruptions. So these aren't patients that were on prior treatment and when I say failing it means that they did not achieve sustained virologic response, either while they were on treatment or either post-treatment. These are patients that started treatment, say they got they were incarcerated, so they got 2 weeks of treatment and then had to stop, or you lost them to care and come to find out 2 years later they come back in and said, oh, I had 4 weeks of treatment. Those are considered treatment interruptions. We don't really know if they were failures or not because you didn't have that follow-up data. There unfortunately are not any current evidence-based recommendations with this scenario, but I would tell you, you know, and this is because most treatment interruptions were either dropped from study data or, like I said, ended up lost to follow-up. But some things to consider are, you know, why was treatment interrupted? Was it a long time ago, like years and years ago? Was it a few months? Far into the course was the patient? So if a patient got a week of Harvoni and then fell out of care for whatever reason, you probably wouldn't need to consider them as a treatment failure. Pharmacokinetics, they probably didn't reach adequate levels for them to develop resistance. But if it's somebody that got 6-7 weeks of Harvoni and then for whatever reason stopped it, you may want to go ahead and consider that an experienced patient. Other things to consider are what measures are you going to do to prevent further treatment interruption? If you're going to try treating them again, how are we going to be more successful this time? Also consider, you know, is this a new or ongoing risk? Is this really a treatment failure or treatment interruption? Or did they actually clear it and then get reinfected? Because then you would just treat them as naive. Consider your genotypes and then consider the evidence we just talked about for retreatment access. And lastly, consider cost and treatment coverage. Next slide. And I think that's my last one. So in summary, just understand that prior treatment failure with interferon-based therapy is really not, it doesn't really significantly impact your treatment response to your DAAs, but prior treatment failure with a regimen that consisted either of or included a DAA have a more significant impact on response rates with retreatment, and that's really if clinically significant RAS is developed during treatment. And then again, how do we overcome that? Either add ribavirin, extend the duration, if you're not able to, you know, use an alternate regimen, or add an additional class like with Vasevi where you're, you know, using 3 agents from all 3 classes. So I think that's it. If you guys have questions, I hope it wasn't too muddled, but
that was great.
That's awesome. Thank you.
We really don't see this very often, but I think, you know, as you go on and continue to treat, you're gonna probably see it at least once at some point in time.
Right.
Maybe, I don't know, but honestly, the guidance is really well. I think the most important thing is just kind of trying to understand what was the prior treatment exposure, so you know what to what retreatment options you have, and really understanding what the classes of agents are, because we kind of throw out there Harvoni, Epclusa, Maverick, let's go with this, but we don't really talk about, you know, what those agents comprise of.
Kaylee, was interferon, was that injection?
Yeah, so interferon alpha, it started, and Dr. Gilfus has done this a lot longer than I am, sorry, but you know, sorry, Dr. Gilfus, but I wasn't around with the interferon era, but you know, in the early 90s it was 6 months, and then it extended to 12 months of treatment. Then they introduced alpha interferon B, and then pegylated interferon, and then added ribavirin. So it started with 6 to 12 month injections, usually once weekly. Gilfus, correct me if I'm wrong, it may have been more than once weekly, but then, you know, in the early 2000s, we were doing ribavirin, which is like multiple pills, multiple daily dosing, plus those 6 to 12 month injections. So if someone's not sure what treatment they had and they just tell you, well, I know I took shots, then I think my next question will be, well, the only injectable we had was interferon, whether it's pegylated or alpha interferon, doesn't really matter to us at this point. Ask them if they took only shots or if they took shots and pills. If they say shots and pills, then try to narrow how long ago was it. So was this still in the, you know, ribavirin era, or was this more recently to where we had some of the first generation protease inhibitors available? Because I'm not going to know what they took. You ask most patients about anything and they don't know what they're taking.
Right.
So that's kind of my approach to weed out maybe what their experience.
Okay, that's because I was thinking about your comment too about the vaccines, but that would be, you could tell that if it was somebody who was not within that interferon era.
Yeah, and yeah, because I'll usually ask them if they say injectables, you know, how long did they take them for? Well, if they tell you 6 months, then your first thought is, okay, it probably was interferon, but then find out, well, I took 3 shots over 3 months, so it's probably a Hep B vaccine.
Right, okay.
That was something that I,
Thanks a bunch.
yeah, you know, had experience with that I never thought about until I was faced with it. So hopefully you guys can learn from that.
Hey, Kaylee, 2 comments. First of all, great job. We're all appreciating that up wheeling, number 1. Number 2, clarification. I also was not providing medical care in the 1990s, by the way.
Yes, you were.
No, I was not.
You were.
And,
You were.
and the last comment is, man, that office room is very well kept. It looks lovely. I like the plan.
I took over Gilchrist's office today. I have really bad reception in mine. Like last time I did a didactic in my office, and I heard later on it cut off like every other word. So hopefully it was better today. But yeah.
And what if those people who've not visited the HCV guideline website, what Kaylee did to add the brand names to the tables is literally worth its weight in gold, because the HCV guidelines never touches brand names, and it makes reading the tables endlessly more complicated, at least to me. And so I really appreciate what you did, and it makes save this PowerPoint, everybody, because it's a lot easier to read than the actual tables on the.
I don't care about being politically correct. I have no disclosures, I promise. I just think that this is ease of our learning, and so it's, you know, I don't care to put the brand name. Sorry, they can get in trouble for it if they want to.
No, that's good.
Yeah, we appreciate it. Thank you so much, Kaylee. And I will attach it in the recap email so everyone has access to it. Any other comments or thoughts you want to share with the group? We still have about 10 minutes left.